You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor.
In 2024, we are highlighting the Cancer Awareness Month in a special series.
We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regimen.
May is Bladder Cancer Awareness Month, and to speak to this, we have Dr. Stephanie Chisolm joining the podcast. Stephanie has her PhD in health education, health promotion from the University of Alabama at Birmingham. Stephanie has been Director of Education and Advocacy at the Bladder Cancer Advocacy Network, or BCAN, for the last 9 years, and she has worked to help raise bladder cancer awareness in the general public and with federal and state legislators. But welcome to the podcast, Stephanie.
Thank you very much, Colin and Dustin. It's really a pleasure to be here. I really appreciate the opportunity during Bladder Cancer Awareness Month.
Can you tell us how you got started with BCAN?
Well, it's interesting. BCAN, we are now in our 19th year, and it started in 2005 when Diane Sapersky-Qualley and her husband, John, who had bladder cancer, were really appalled at the lack of information and the lack of federal funding for research into bladder cancer, even though it's consistently in the top 10 cancers diagnosed in America. So they decided to go ahead and start the organization. And I was working at a parallel organization doing all things urologic and doing patient education there. So I would partner with them frequently on program. And Diane, who is the co-founder, would say, I'll do a program, but only if it's just bladder cancer, because nobody talks about bladder cancer. And when I came on board officially at BCAN, that was still the case. There are so many people that tell me, I had no idea you could even get cancer in your bladder until my doctor gave me my diagnosis. So Bladder Cancer Awareness Month is one way that we hope to raise awareness about the signs and symptoms. What do you do? Where can you go? And also help support our fundraising efforts to increase our funding ability to support the research that's going on to make a difference in the lives of bladder cancer patients from a clinical medical perspective.
And can you tell us about the bladder cancer, perhaps prevalence?
Sure. Again, I told you, most people don't know you can even get cancer in your bladder, but in the United States, it's actually the sixth most common cancer that nobody ever talks about, in part because it has to do with urination, maybe, but there's a lot of stigma and embarrassment about it. And the prevalence across the country really varies by region. There are certain things that could put you at risk that might be environmental. Other things could be behavioral, and some are even occupational, which put people in different areas at greater risk. Bladder cancer is more prevalent in the older community. The majority of bladder cancer cases are diagnosed in individuals over the age of 60, and the average age is around 70. Men are about 3 times more likely to develop bladder cancer than women, but for a lot of reasons. When women are diagnosed, it's often at a later stage, and they usually have a more advanced disease and perhaps a worse prognosis, really referring to the outcomes of the disease journey. And there's a lot to be said for making people aware of the signs and symptoms. We will talk a little bit too about bladder cancer in younger individuals, people under the age of 50. And while it doesn't happen as often, it does happen. And BCAN, the Bladder Cancer Advocacy Network, keeps meeting more and more younger individuals who've been diagnosed with bladder cancer. And in part, it may be a challenge because many healthcare providers don't initially consider bladder cancer as a likely diagnosis when younger individuals present with urinary symptoms that are common for bladder cancer, like hematuria or blood in your urine, and urgency and frequency. For instance, for men who have maybe urgency and frequency, if they're under the age of 60 and they don't have other known risk factors, doctors might initially just assume that they're having enlarged prostate issues, which the prostate can cause problems with urination, and not actually look for bladder cancer. So that's certainly a big issue. In terms of looking at cancer prevalence, we know that it's more prevalent among smokers because of exposures to carcinogens that get into your bloodstream after they leave your lungs and you smoke. All those chemicals go into your bloodstream and then they go down to your kidneys, and your kidneys make your urine, and that urine with all those chemicals sits in your bladder until you void it out or pee it out at a later time. And that could change the lining of that bladder and cause the mutations that allow that cancer to develop. When you think about it, it's the sixth most common cancer in America, but globally, bladder cancer is also among the top 10 cancers that affect more than 1 million people annually. This year alone, there are going to be over 80,000 people diagnosed with bladder cancer in the United States. You add that to the more than 1 million that are going to be diagnosed across the globe. That's a lot of people. And some of the bladder cancers that happen globally are because of things like big communities where smoking is very prevalent. That may be one thing, but there's even in places like sub-Saharan Africa, the Middle East, or South America, Southeast Asia. You know what? With such a high prevalence, your listeners are probably wondering why their doctors just don't screen them for bladder cancer, right? Mm-hmm. And with prostate cancer, you can get a PSA test, and that's one way to look at changes in your prostate. For breast cancer, you can have a mammogram, and that will detect breast cancer early. But we don't have a screening test for bladder cancer. The diagnosis typically comes after an individual might have signs or symptoms, something like hematuria, blood in their urine. This can be microscopic, found on a urine test. When you go to your doctor's office and they ask you for a urine sample, they're looking for blood cells in your urine, and that's microscopic hematuria. Or hematuria can also be gross, and not just gross in that it looks scary because you see a lot of blood in your urine, but gross in terms of the actual volume where you can see the blood with your eye. That is another sign of bladder cancer. Sometimes urgency and frequency, I've got to go, or I have to go a lot, which often happens as you get older anyway, are other signs of bladder cancer. And then sometimes bladder cancer is found by accident. But you think, how is it found by accident? But maybe the doctor's doing an MRI or an ultrasound for something else, and they happen to pass over or look at the bladder and see something in there that needs further explanation or exploration to determine what's going on. So there's been a lot of research by many talented clinicians and researchers, even some that are funded by Bladder Cancer Advocacy Network research funds, that are aiming to improve treatment strategies, diagnostics, and understanding of bladder cancer. And just like all cancers, awareness, prevention efforts, and advancements in research and treatment are essential to address the impact of bladder cancer and improve outcomes for affected individuals. So that was really why Diane and John Qualley started the organization 19 years ago. And it's really our mission to keep going, to raise awareness, to support the research, and provide education and support for those who are impacted by bladder cancer.
So it sounds like a lot of patients, like younger patients or women, are having a delayed diagnosis because there's not really a lot of screening in place. Is that correct?
There is no screening. So it's until you end up with signs or symptoms, you wouldn't even go. And for women, they often think that the urologist, who is the medical specialist who's trained to diagnose and treat diseases of the urinary tract. Many women think, the urologist is my husband's doctor or my father's doctor. They don't think of even going to a urologist. And younger people, that hematuria that you might notice could be very steady and very obvious, where you see this blood and you're thinking, oh my goodness. Or it could be intermittent. It starts and stops just about the time that you think, wow, maybe I should go talk to the doctor because I don't think I should be peeing blood. And it goes away. Some people think I dodged a bullet. It went away, so there's no problem. But you don't know that. It can come back. So a lot of younger people that might have signs and symptoms don't necessarily know to go and get checked out. And even when they do, perhaps they see it as something else. And until you go to the correct doctor, which would be a urologist, they have the equipment to actually look inside your bladder. It's called cystoscopy. They use a thin fiber optic camera. It goes through the urethra and looks around, shines a light that the urologist can see inside the bladder and spot a tumor, which could be papillary, that looks a little bit like a sea anemone, or flat, where it just looks like an irritation in the bladder, that then could be biopsied or removed so they can determine if it's cancer or something else. So when you have the signs and symptoms, particularly like blood in your urine, that's never normal. It's always important to get checked out, even for younger patients.
And I was hearing that you had highlighted some of the risk factors, specifically behavioral risk factors of smoking, some of the parasitic as far as like the environmental. Wanted to see if you could just maybe expand on that and share if there's other risk factors of bladder cancer.
Oh, absolutely. I can definitely talk about that. It's really important to just bring it up right from the front, though. There are a lot of patients, people who are diagnosed with bladder cancer, whether they're currently in treatment or they're long-term survivors, that say, I never smoked. I never lived in an environment that had potential toxins that I know about. And so there are some people that never know what the cause of their bladder cancer would be. But certainly we know that behavioral risk factors like smoking is one of the most significant contributors to bladder cancer. A lot of people think, sure, smoking is connected to lung cancer. I breathe it in, it gets in my lungs, but I don't have lung cancer. And so they don't worry about it. But your lungs filter out all of those toxins and put them into your bloodstream. They go down to your kidneys and then they end up sitting in your bladder. And so that's how the smoking connection is. Those carcinogens can cause problems in your bladder, mutations in the cell lining, and that can trigger bladder cancer. Other kinds of things include occupational exposure. If people work with certain chemicals, dyes, paints, organic compounds, they may have an increased risk of bladder cancer. We know that the firefighter community, because they're exposed to so many carcinogens, not only in the smoke that they might breathe in, but it gets on their clothing, it gets on their turnout gear that they wear to fight a fire. Even when they're cleaning up afterwards and there's what they call off-gassing from the fire, if they're not wearing protective gear, they can certainly put that into their lungs. But the stuff that lands on their skin or on their clothing can get in that way as well and can cause bladder cancer at a later time. Certain occupations are at greater risk. And then even in some environments, for instance, certain areas where water tables have elevated rates of arsenic. Arsenic is a known bladder cancer cause. And depending on the well systems that people might have, there are certain parts of the country that have high rates of arsenic in the water, and that can contribute to bladder cancer. And I just want to share something that I think really fascinating, because BCAN had an opportunity at our scientific meeting that we offered our medical community last year. We brought in folks from the Clinical Translational Science Award One Health Alliance, or COA. And they are an integrative group of multidisciplinary physicians and researchers that work together. And mostly veterinarians that partner with their medical colleagues to advance our understanding and diseases that are shared by humans and their pets, particularly dogs. Dogs have naturally occurring bladder cancer. And so they're doing some really unique research to examine the things that the dogs might be exposed to and also the people that live in the house with those dogs. So there are things we don't even know yet that could be triggering bladder cancer. And it's wonderful to have this new collaboration forming with the team from COA because we are living in the same world and our pets live with us as humans and we're all exposed to the same things. Sometimes chronic bladder inflammation or infections could be a cause of bladder cancer or it could be early signs before the cancer is even visible. And I know you both had experience growing up with cancer. And when a parent has a child with any type of cancer, you want to do anything you can to attack that cancer. But we know that certain chemotherapy drugs like cyclophosphamide, when it's used over an extended period of time, can elevate the risk of bladder cancer. So even childhood cancer treatments that a child is going through and a parent is making decisions on treating them, they're often most concerned about making sure their child is surviving and not thinking about 20 or 30 years down the road where the very treatment could be a thing that could put them at greater risk for bladder cancer down the road. So there's a lot of risk factors. While it's essential to point out that these things can create an increased risk, there's no guarantee that anybody who was exposed to chemotherapy because of cancer would develop bladder cancer, or anybody that smokes or is a fireman or anything like that. There's just things that when you put it all together, sometimes it does illuminate different things that might be increased risks. Did that answer your question?
Very thoroughly. Thank you very much for that.
I did forget, and I should mention our military veterans that have been exposed to Agent Orange and other rainbow herbicides during Vietnam wars, and then the chemicals that are in burn pits in modern warfare may also have increased risks of bladder cancer. We know that in the veteran community, in the male veteran community, because there are female veterans as well, but in the male veteran community, particularly with the slightly older Vietnam era veterans, bladder cancer is the fourth most common cancer in that community. And they know that the PFAS man-made chemicals that are used in a lot of products like military firefighting foams may have contaminated groundwater in certain military bases or communities. And so there is a greater risk in the veteran community as well. You know, if any of your listeners want to find out more about it, because BCAN is advocating on behalf of our veterans of modern warfare to make sure that the burn pit legislation that covers veterans for occupational exposures is also including bladder cancer, the PACT Act. So you can visit our website, bcan.org, and on the Find Support tab, go to the page for veterans and bladder cancer, and there's more information there.
Okay, so that was a very thorough response. And can you tell us about the field effects?
Sure. I've been going on and on about smoking and things that get into your bloodstream, things that you could be exposed to. Maybe it's not so common for people that just had their hair dyed, but people who are hairdressers that used to work with hair dyes every single day as part of their jobs. And before we knew what we know now, they probably did it without wearing rubber gloves in the earlier years. They're all exposed to carcinogens. They get into your bloodstream. They go through and into your urine. And all of the cells that line your urinary system are called urothelial cells. So when a carcinogen comes in contact with these urothelial cells, sometimes it triggers a genetic change And anything that triggers a genetic change or a mutation that then later flips to what I call the dark side and turns into cancer is potentially the same thing that could have impacted another cell anywhere in the bladder or anywhere in the ureters, the tubes that lead from the kidneys, or anywhere in the urethra, the tube that leads out of the bladder so that you can void or empty your urine. So I'm a big gardener. I have a big garden in my yard, both vegetables and flowers. And I like the analogy of bladder cancer being a little bit like a dandelion. Do either of you garden?
I've not had too much experience with gardening.
You've probably seen a dandelion, right?
Absolutely.
If you like your lawn, and there are a lot of people that really like a nice green lawn, and they want to get rid of that dandelion. So you go and you dig out the dandelion. But if that little puff had formed, a little poopy thing, before you got there, if one of those puffs blew off, that dandelion might pop up elsewhere, even though you dig out the dandelion. And did you really get all the roots? So maybe you didn't. But it may just be that those puffs that started that first dandelion had sister or brother puffs that landed somewhere nearby, and they're just waiting for the right conditions for them to grow. And so that's a quick analogy about what the field effect is like. Did that explain it for you?
Yeah, I think it did.
Okay. Sometimes more than one dandelion puff blows into your yard, and you wouldn't know that. But you can dig out the tumor, they can scrape it out. We'll talk about that in a little bit, but that doesn't mean it won't come back. And so surveillance is really important. And that means going back in there with that cystoscopy, that special fiber optic camera, to look around the bladder to see if those tumors come back. It makes bladder cancer very expensive and creates a lot of anxiety when you have to go back for regular scans, which is a very invasive procedure. It's not a simple blood test, or mammograms aren't necessarily simple, but it's not as invasive of having a little fiber optic camera to put into your urethra and up into your bladder.
And what is the standard of care for bladder cancer?
Oh, excellent question. It's really fascinating because bladder cancer is not like one particular thing that you can say there's one particular treatment that works for all bladder cancer. So I'd like to just have you envision for a second an iceberg. And bladder cancer has different levels of diagnosis. Bulk of the iceberg, the big chunk of ice that's under the water, about 50% of all bladder cancer cases are what we call non-muscle invasive. That means the tumor is on the urothelial lining of the bladder itself, which is unique in that it's meant to keep the yucky stuff in your urine from being reabsorbed back into your bloodstream. So in order to treat it, they need to treat it intravesically, which means inside the bladder. And then another 33% of people with bladder cancer have what they call muscle invasive bladder cancer. That means for whatever reason, either the tumor was very aggressive and moved quickly, or they weren't diagnosed and the tumor had plenty of time to seep into the muscle wall that holds that bladder together. But when it gets into the muscle, it has the opportunity to get into your lymphatic system, which runs throughout your body, or your circulatory system. So the odds of that spreading are much greater. And the standard of care under those circumstances is to have the bladder removed and have a urinary diversion created. And I'll talk about that in a second. But then the last and smallest percentage of bladder cancer patients are about 17 to 20% of bladder cancer patients are diagnosed with either locally advanced cancer that has moved outside of the bladder and into other parts of the pelvis, like the prostate or other tissues nearby, or metastatic where it might be as far away as your brain or your lungs or your liver. Those are the smallest percentage, and those are typically treated systemically with things like chemotherapy or immune therapy. And now we have some targeted therapies that can be used to look at specific genetic mutations in a tumor and almost be the key that unlocks the cure, or finding a mutation sometimes can help select treatments for patients with metastatic or advanced disease that statistically aren't going to work if they have that particular kind of a medication. So why expose them to the potential side effects? So there's a lot of different ways that bladder cancer is treated. So standard of care for non-muscle invasive, where the tumor is located in the bladder, is first a TURBT, or a transurethral resection of the bladder tumor. The urologist is the doctor that does that. They're the ones that are trained specifically, and they have the equipment to do this. They go in with a little fiber optic resectoscope that has a little wire on it that can scrape out that tumor. And then they can send that tumor to the pathologist, who determines the stage of that cancer and the grade of that cancer. The stage, is it non-muscle invasive? Is it muscle invasive? And the grade is, how aggressive does it look? Because those are the things that are going to help guide your doctors to suggest the best treatments for you. And then what I mentioned earlier, the intravesical therapy, where the medication is placed directly into the bladder to help prevent a recurrence. And one of the oldest forms of immunotherapy is Bacillus calmette-guerin, or a weakened form of the tuberculosis virus that is put into the bladder. And it actually can help, once the tumor's been scraped out, prevent recurrence. It doesn't work for everybody, but it does work for a lot of patients. Right now, we're in the middle of a global shortage of the type of BCG, Bacillus calmette-guerin, that is approved in the United States. And so they sometimes will not give a full dose, but it can work. And if an individual doesn't respond to BCG, they could potentially have some chemotherapy put into the bladder, or there's a new gene therapy that is instilled into the bladder. It's an intravesical therapy, but it triggers your body to produce more interferon and can help reduce the risk of bladder cancer coming back. For muscle invasive, as I mentioned, a radical cystectomy, removing the bladder, which for men also includes nearby organs like the prostate, the seminal vesicles, and for women may include removal of the uterus or the cervix, sometimes the fallopian tubes, maybe even the ovaries, and perhaps, depending on the location of the tumor, a woman's vagina might become a little bit shorter as a result. And then a urinary diversion can be created where either there is a short stoma, a piece of intestine is connected to the kidneys, and the urine leaves the body through that little stoma and goes to a bag on the outside of a person's body. And then they just empty the bag like they would going to the bathroom. Or there are some doctors who can create a new bladder called a neobladder that uses a slightly larger piece of intestine that's stitched together to create a little cutaneous under the skin pouch that then a person with bladder cancer needs to learn how to control and empty that bladder. But it's an internal bladder that's connected to their urethra, so they void normally. Or there's another type, a cutaneous pouch, that is connected to a stoma that's usually located right behind the belly button. And then the individual can put a catheter, a little tube in, and drain that bladder that way. So there are ways to live without a bladder. There's also chemotherapy. And for some patients who are not good candidates, perhaps because they have other comorbidities or illnesses. They might not be a candidate for bladder removal surgery, and maybe they are more interested in preserving their bladder with what we call trimodality therapy, which uses some radiation, selective surgery, and chemotherapy in combination. I think that covers the muscle invasive. For metastatic, I may be repeating myself, but systemic chemotherapy, immunotherapy using checkpoint inhibitors can stimulate your body's immune system to attack the cancer cells. Targeted therapies can also be used. And the good news is we now have options. 5 or 8 years ago, 9 years ago, when I first started at Beacon, there weren't a whole lot of options. If chemotherapy didn't work for people with advanced disease, they were basically told to get their affairs in order. And now at our scientific meeting, we have sessions about sequencing. What do you do to sequence types of treatment? So the good news is there are options. There are more options for patients with advanced disease. The bad news is there's still patients diagnosed with advanced disease, but hopefully raising awareness and helping patients know to get in early when it's important and has a better likelihood of having successful treatment in their diagnosis. Through this podcast and all the work that Beacon does will hopefully reduce those numbers of people with advanced disease.
How has immunotherapy affected the treatment of bladder cancer?
We all rejoiced when the first immunotherapy was approved about 8 years ago. It changed everything because, as I just mentioned, prior to that, patients with advanced disease were given chemotherapy. And nobody loves chemotherapy because we all know what it does to you. It makes you very sick. It kills healthy cells as well as cancer cells. And nobody volunteers to have chemotherapy unless they really need it. Nobody wants to do it. To suddenly have another option means that patients aren't told it didn't work, we have nothing left to offer you. So now there are multiple types of immunotherapy, particularly the immune checkpoint inhibitors like pembrolizumab, atezolizumab, nivolumab. They all have demonstrated effectiveness, and they work by blocking specific proteins that inhibit the immune system. It's almost like cancer in general has the ability to, if anybody listening is a Harry Potter fan, to almost put like a cloak of invisibility over itself so that your body's immune system can't see it. And so these immunotherapies, I envision these as being like somebody's pulling up that cloak of invisibility saying, under here, the cancer is here, you can get it. And it helps your body to fight off the cancer that way. So it's really led to improved survival rates, given more treatment options. Sometimes it can be provided neoadjuvantly. That means before maybe even the bladder removal, they might go through some rounds of immunotherapy or even chemotherapy to help get rid of any cells that are outside of the bladder. Let's say a patient has muscle invasive disease and the doctor's saying the best approach for us is going to be to take out the bladder and reduce your risk of that cancer coming back. So I'd like to give you neoadjuvant chemotherapy or neoadjuvant immunotherapy. And the patient says, well, if it's going to knock it out before you take out my bladder, why do you have to take out my bladder? But it's just an extra level of insurance. Sometimes adjuvant therapy is given after the main therapy. So it's just adding extra protection. So having the immune therapies gives people some options. We don't necessarily have to rely on platinum-based chemotherapy as often, but it's still considered the standard of care in advanced disease. For some patients, a lot of patients, they have more durable responses. They can be more long-lasting. At the same time, they also come with their own potential risks. When your immune system becomes compromised with immunotherapy, something that might not be a problem when you have a healthy immune system, can become a problem. A common cold can escalate into something much greater. And so it's really important to make sure that a patient who's on immune therapy communicates any signs or side effects to their doctor so that they can make sure that they're being monitored and that any of these side effects, or they often call them adverse events, are not life-threatening.
Thank you so much for bringing in a pop culture reference, because as you were talking about immunotherapies, one came to mind for me as well. I was just thinking of the inhibitors as like are they called the kings of old from the Lord of the Rings? They're activated to then fight.
Yeah.
So that's where my mind went, and I'm like similar. I like the reference to the cloak of invisibility there. But since we've talked about the standards of care for treatment, I also wanted to speak to the common treatment effects and maybe the late effects of that treatment for bladder cancer.
Oh, absolutely. That's the biggest issue, obviously. It would be nice if you could just have the treatment and we get rid of your cancer for whatever cancer you have. But especially systemic therapies have the opportunity to take out good, healthy cells and cause damage as well. And more local things like surgery, bladder removal surgery. When they do the surgery, there are a lot of potential side effects that can really impact quality of life. Might save somebody's life, but I've heard patients describe it as, yeah, they saved my life, but they took away some of the best parts. For instance, during a radical cystectomy where they remove the bladder, there are a lot of nerves in and around the bladder area and the pelvic floor for both men and women. Nerves that are responsible for erections in men and vaginal lubrication in women. And if they're damaged or removed with the other tissue, then sexual function might be a huge impact. Continence is not always guaranteed, even with, say, a newly formed bladder that uses your intestine and is hooked up to, there's no guarantee with things like a neobladder that you're going to be able to have continence 24 hours a day, meaning you can't always hold your urine. And at the same time, sometimes, because you're using intestines to create the pouch or this urinary diversion to a bag outside your body, that intestine has mucus in it and it can get clogged. And so some individuals with these different diversions need to catheterize to be able to fully empty out those bladders. So talking to your doctor about concerns is really important. For women, if their vagina ends up being shortened, there are lots of things that can be done, but without discussing it with your doctor, they won't know that this is a problem for you. So while it may be really challenging and sometimes embarrassing, and people who are diagnosed with cancer, their first thought is, oh my God, get it out. I have cancer. This is a problem. They're not thinking about the long-term effects. And quite honestly, some doctors don't necessarily think, remember I mentioned that most bladder cancer patients tend to be on the older side, over 70. They don't think much about sexual functioning in older individuals unless they are themselves. And so they might not even bring it up. And if they do bring it up, again, the individual with cancer and their loved one are thinking, I just got to get rid of this cancer. This is the most scary thing in front of me right now. And they don't always stop to ask those kinds of questions. So it's really important to talk about what are the potential treatment effects and how can you make them better or avoid some of these potential problems. So like when you're picking the doctor to do a surgery, you want to ask about their functional outcomes in their other patients. So it's always good. It's always good to be able to speak to somebody that does this all the time because they're very tuned in and aware of some of the potential problems that can occur. So I think that, again, there's many side effects. There are a lot of things that the medical team can do to help mitigate some of those side effects, but only if you remember to share that information. Don't ever think that your doctor or your medical team is, oh, it's not that important to them. They're not even going to ask me. I shouldn't bring it up, because it is important. If it's important to you, you need to make sure you bring these things up. And in the case of sexual health and continence, holding your urine, pelvic floor physical therapy can be really beneficial. Sometimes, even before the surgery, we are funding a research study right now that's really helping to help patients prepare in the sense of prehabilitation, getting your body ready. It's a pretty significant surgery to have your bladder removed. And to be in better shape means you're likely to have better outcomes. So ask your doctor, what should I be doing before my bladder removal surgery? Or what should I be doing prior to my treatment that is going to help me get through this treatment in an easier fashion? You have to ask those questions. It's really important.
Yeah, to be that self-advocate for the treatment and your concerns. I wanted to thank you for being with us today. And also just wanted to maybe open that up and see if there was anything else you wanted to speak to regarding bladder cancer awareness for May.
I appreciate the opportunity. I think that for listeners that had never heard about bladder cancer before, or people that have bladder cancer and are going through treatment and never knew that BCAN, the Bladder Cancer Advocacy Network, exists, first of all, I want to say our website is incredibly comprehensive. We have everything. We have podcasts, much like this one, but they only do bladder cancer topics. We're open 24 hours a day, 7 days a week. We have animations. We have webinars. We have printed content that you can download or request and we'll mail it to you, and all kinds of information about every aspect of bladder cancer, from diagnosis and prevention all the way through to survivorship and thriving beyond your bladder cancer. So visit our website, BCAN.org, and you'll find just about anything you could possibly imagine. And during Bladder Cancer Awareness Month, we have walks around the country. I think there's close to 20 cities where we're doing big walks. Maybe you'll meet some of the BCAN staff if you go to one of the walks, but you can find that on our website as well. When you've got 200 people walking through a city with bright orange shirts on, because orange is our color, it does a lot to raise awareness. People are like, why are they walking? And they read the shirt and say, Bladder Cancer Awareness Month. I had no idea you can get cancer in your bladder. So again, we're open 24 hours a day, 7 days a week at BCAN.org. We have a call center that is in partnership with Cancer Care, and that number's on our website. And you can call ASK number 4 BCA during regular business hours, New York time, and speak to a social worker who can help you find resources in your community as well. We've got an app. We've got just an entire library of information. And I thank you both for shining a light on bladder cancer, the 6th most common cancer that nobody talks about.
Shining a beacon on BCAN, right?
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media at Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.